Good morning, everybody. I hope that I don't give you a seizure today, but regrettably, I'm a Mac user and I don't trust PowerPoint to do things with my presentations that I don't want to have done. My name is Casey Glass. I'm one of the assistant professors in emergency medicine at Wake Forest, and I'm here today to talk to you about chronic abdominal pain. So, how many of you are the first to sign up for these patients when they show up on the board at work? Probably not. So if you're in the audience today, I assume it's because you find these patients frustrating and you're hoping to get some tips on how to manage these patients in a way that leaves you feeling better about that interaction and I believe moves these patients towards better health. So first, I don't have any disclosures to make. And we're going to start our case with a woman named Jane, and this is a fictitious name for a real person that we see in our emergency department. And this woman has been a patient with us for years and years, and she's in maybe about once a month or every other week for abdominal pain. She had a rough history. She had abdominal hernia repair that had a number of complications, but for the last several years, her symptoms have been pretty stable. She's had 6 CT scans in the last year, no new pathologic findings. She usually comes in, gets a bunch of labs, some IV fluids, IV narcotics, very frequently admitted to the hospital. And it's for patients like this that, I would just leave those encounters and I would just feel bad. Like I felt bad I couldn't help this person. I was kind of frustrated. Felt like, the emergency department is not the place for a patient like this. There's nothing we can do to help these people. And it's out of that this talk really came, kind of digging into this and preparing some content both for our faculty and residents and looking into what really is behind chronic abdominal pain. And one of the challenges is that chronic abdominal pain is really a number of diagnoses, and this is not a surprise to you. And so there are names for some real described syndromes that these patients have, and we're going to talk a little bit about that. But one of probably the core pathology, the real center patient for our conversation today is going to be the patient with centrally mediated abdominal pain. So this is really the remainder after we've gone through this list, that patient who has no other better diagnosis for their pain, no structural diagnosis. And before we get to that, we have to talk about a couple of other things that may masquerade as centrally mediated abdominal pain. Because there are a few diagnoses that are fast and easy to make at the bedside. And in my experience, the challenge is that emergency physicians simply don't know about them. They do not know that they exist, or maybe don't understand the prevalence in this patient population. The first one is abdominal wall pain. So I'm sure we've all examined patients who, after looking at them, we thought probably had pain that was more isolated to the abdominal wall. But most physicians are not familiar with this as a chronic pain syndrome. And in fact, maybe about 20 or 30% of abdominal pain presentations that are not from other pathology, so undifferentiated after an evaluation, may be due to abdominal wall pain. And the problem here is that the cutaneous nerves kind of come up through these fibrous rings in the rectus abdominis. And as patients age and their girth increases, it puts traction on these nerves and they can get radicular pain. And the way that's experienced may not be classically radicular. They may have very focal pain over the fibrous ring. They may have other focal pain along the tract of the nerve, or the excitation of the dorsal horn may give them more of a regional pain. And the diagnostic maneuver here is Carnet's sign, where you simply have the patient flex their abdominal muscles. Classically, you just kind of ask them to pick their shoulders up off the bed. And if that increases their pain in the spot where they can indicate it's the worst, that would be a positive finding. And the treatment for this is simply to block that. And so in my own practice, what I'll do is take the point of care ultrasound machine and I'll just look under there and make sure there's no other unusual pathology. There's really just skin and sub-Q tissue that we're looking at. And in my own practice, I put about 20 cc's of Marcaine there. In the literature, if you treat these patients regularly, ideally you're going to find the fibrous ring at the rectus abdominis and go ahead and do a nerve block at that location. That's probably a little bit much for most emergency physicians. And the diagnosis of this is made after repeat visits. So if the patient continually has these symptoms and the blocks continually give them relief, you have essentially made the diagnosis of abdominal myofascial pain syndrome. The other mimic is simply one of the many functional abdominal pain disorders. And in fact, we probably need to be a little bit better about identifying these, because a lot of these patients simply probably have irritable bowel syndrome. And if they could simply know that their illness is in that spectrum of disorders, they would feel empowered to go ahead and get more care for it. It's definitely been my experience that all of these patients feel a lot better about both the treatment they get in the emergency department and what they need to do after the emergency department simply having some idea what the name for the thing is that they have. And the functional disorders really are characterized most specifically by the relationship to either food or other temporal gut events like stooling. So for irritable bowel syndrome, the symptoms get worse and stooling changes. For functional dyspepsia, the symptoms are worse after eating. And on further GI evaluation, there's no actual pathologic findings, so the scope is normal, pH probe is normal, those sorts of things. The Rome criteria are still the best diagnostic tool for this. It's easy to get at. Your calculator on your phone probably has them if you want to delve into that more with your patient. And then lastly is narcotic bowel syndrome or opioid-induced hyperalgesia of the gut. This is a fairly new diagnostic entity, and it's something you can see in patients on chronic opiate therapy, usually not small doses, at least kind of 80 milligrams of morphine equivalent a day. And these patients get hyperalgesia of the gut. They develop, again, chronic abdominal pain. The diagnosis is made by withdrawing narcotic therapy, which makes the symptoms worse, resuming it, which makes it better, and unfortunately the treatment is simply to withdraw narcotics altogether, which is, of course, going to take a lot of involvement from the physicians who are prescribing that in the first place. And again, if you're just walking in, I'm sorry for the flickering. I'm that presenter who won't use PowerPoint. So we're going to spend the last 10 minutes or so talking about centrally mediated abdominal pain, because this, quite frankly, is why I asked you to come here, and this is maybe the one place where I feel like sharing some knowledge with you will empower you to work with these patients in a different way. So centrally mediated abdominal pain is really well named. It is a disorder of pain processing that involves both the gut and the brain. And in studies of it, it's probably about 1% of these abdominal pain patients. There's a 2-to-1 female to male predominance, and the peak age incidence is probably around age 40. There are specific diagnostic criteria, so your patient should have pain pretty much all the time. It should not really be specifically related to other events like eating or stooling. That would move it over into the functional pain category. It has to have some impact on their life. So if they just get along with it and it doesn't seem to bother them, then they would not meet the criteria. They can't be malingering. In the case of the patient we're talking about today, Jane, I know her well. I've seen her for many years. It's really my impression that she's not a malingerer. But you may need to do some research, look through their medical records and talk to their other providers to know if that's really the case. And then again, they need to have had an adequate workup to determine there's not a real structural cause for their symptoms. It's an interesting study of these patients who got a small capsule endoscopy, and about 15 to 20% of these patients who had other standard testing and continued to have pain had a lesion that was responsible, like a small bowel ulcer or a Meckel's diverticulum that once treated also resolved their symptoms. So an important thing when you're talking to these patients is that 10 to 15% of them, 15 to 20% of them may still have a structural diagnosis, even though they've had a pretty exhaustive set of tests from our perspective, including CTs and endoscopies and colonoscopies. Even then, about 15 to 20% of them may have a structural diagnosis for their pain. And what's going on here is similar to most of the other chronic pain disorders. The gut delivers a set of noxious stimuli to the brain, and this is happening all day long, no matter what's happening to you. And in patients, or in individuals rather, with normal pain processing, the brain suppresses those signals and you don't experience them. It sends negative feedback to the gut to get it to cut it out. And for some reason, in patients who experience these persistent pain symptoms, that central regulation of the in and out pain signals from the gut is disordered and often feeds forward. In functional MRI studies of patients with chronic pain, there's increased activation of the limbic system compared to normal individuals. And in fact, structurally, they have increased cortical thickness. So there's real brain changes that are part of this problem. And of course, the pain signals are one thing, and what really changes your average chronic pain patient from the difficult patients we see in the emergency department is a lot of other factors that affect the pain experience. And certainly, for me at least, the patients that I know often suffer from a lot of these other things which make them unable to manage their pain symptoms at home. So we know that a history of life trauma, lack of social support, all lead to an increased experience of the pain syndrome, even though if we were to compare two individuals, someone with better social support may have a similar problem but won't experience the pain to such a great deal as far as being a life disturbance. So for these patients, their symptoms are real, and that's the first thing really to go home with. It can be hard to validate their experience. These are patients who are very challenging, who we work up frequently and don't find anything wrong with them. But this is a real experience. They're not making it up. This is not something that's all in their head. This is a real experience. But they do have a tendency to catastrophize. And if you're not familiar with the idea of catastrophizing, this is your patient who says they have intractable nausea and vomiting, that they haven't been able to keep anything down at home. But when you get into it, they vomited one time before they came in, and they've been in your emergency department for 2 hours with no vomiting. So that's catastrophizing, just the idea that, my pain is 10 out of 10 and I have intractable nausea, vomiting. But from an objective perspective, the symptoms seem pretty mild. The one thing that you need to be able to talk to these patients about is that this is a real problem and that there are real treatments that can help improve their symptoms. And I think that that's one thing we don't often understand, or that we really don't know because we're not their long-term physicians. But this is pretty well described in the gastroenterology literature. There are well-described treatments for this that will improve symptoms. They need to have a gastroenterologist, as much as you might want to refer them to chronic pain. In my discussions both with chronic pain physicians and gastroenterologists, chronic pain physicians don't know anything about this, and the gastroenterologists believe that the chronic pain physicians don't know anything about this and that they should see a gastroenterologist. But of course you need to have a gastroenterologist who's willing to take care of these patients. They are challenging, and when I talk to ours, they're like, yes, we are their doctors, but they tend to be pretty difficult. And they don't always want to participate in the therapies that are going to make them better, and that certainly can be true. Most of the time when we see them in the emergency department, we don't need to do a lot of testing, and I'm going to talk a little bit more about that in a minute. And then those comorbid mental health conditions need to be treated because, of course, that's going to improve their ability to cope at home. And in fact, cognitive behavioral therapy all by itself can be very useful for improving their symptoms. And finally, medical treatment with TCAs and SSRIs can be pretty helpful. And patients sometimes feel uncomfortable being placed on psychiatric medications. So they're like, well, you told me this wasn't all in my head, but now you're putting me on crazy people medicines. And so usually you do need to have some conversation about that, and that, oftentimes we try medicines that are otherwise used for depression for this condition, but we're not so much worried about depression. It's the nerves that are misbehaving, and we need to use medicines that can affect the nerves to help improve your symptoms. And I've had very good buy-in from patients when we approach it from that perspective. I personally don't usually start these from the emergency department. I leave those for the gastroenterologist. I will start them from the emergency department if the patient has a gastroenterologist, and often I will just talk to them and say, hey, have we ever done this? And they're like, I haven't ever really done that, but I'm happy to follow up on that if you want to start them at a low dose on that. So let's take this back to the bedside with Jane. So Jane, as I mentioned, is having her typical symptoms. She has been worked up ad nauseum over the last year, and this is pretty usual for her. So the first step really that's really important is to develop some empathy with your patients. I can't stress enough how important a positive therapeutic relationship is, and that is challenge number one for us. Again, these patients are frustrating. When you see them on the board, kind of pulling your hair out, you just saw them a week ago. But if you can't build empathy at the bedside, none of the rest of this works because of the psychological component to it. This is a real disease. It's really happening in their heads, but the ability to moderate those symptoms with attitude and behavior is very powerful. And so you really do need to build a positive relationship. And so my own approach is simply to say, I'm sorry you're feeling really bad today. Jane, we've worked together before, and I know that these symptoms are very difficult for you. What's going on today? And, let's see if we can make this better, and we'll see if there's something new that we might be able to try that'll make you feel better today. Any testing really needs to be directed towards red flag symptoms. It'd be unusual to see this for the first time in someone who's age over 50. We all know we're working that person up for cancer or other badness. Certainly weight loss is likewise a big risk factor for undiagnosed intra-abdominal badness. rectal bleeding, and then especially, as always, a change in their GI symptoms. You know, if we're going down the chronic central mediated abdominal pain pathway, it should be their typical symptoms that we're working with that day. Outside of that, you know, repeat CT scans, LFTs, CBCs, these things are not typically value added. Really base any additional evaluation around your normal physical and history findings that might make you worried about something new or different. As with all kind of chronic patients, it's important to set an agenda or kind of set expectations for what we might accomplish in that visit. And so usually I will give them some leading ideas about where we're going with this visit in terms of, you know, I'm going to improve your symptoms. I probably can't make them go away. Hopefully, you know, if they get a little bit better and you can keep some stuff down, I'm going to be able to send you home again. And if not, certainly we'll be trying other things to make you feel better. An important part of that is that you need to lay out from the beginning that you might not be giving them their IV hydromorphone or their IV Phenergan or the things they have come to expect. Those medications are not going to work on these gut neuropathways or in their brain, at least not on the pathways we want them to. And so I usually will do some coaching that we might want to try something different today that can work on the nerves that I believe are part of your problem and see if that will help improve the symptoms. And quite honestly, the things new are all off-label and unstudied. So I'm going to say that right out front. The literature behind this is essentially zero or very small. There are a couple of studies. Oops, I got past them too fast there. A couple of studies on haloperidol and gastroparesis, which are early but promising. And if any of you are looking for some research to do, randomized studies for these patients would be super helpful. They are a little bit hard to identify because the criteria are pretty strict. So to truly enroll centrally mediated abdominal pain patients means that, you know, you're going to have patients who have had an adequate evaluation by gastroenterology. And so it can be a little bit challenging to identify them as a study population. My personal preference, and I'm totally going anecdote here, is haloperidol IV. If you're uncomfortable giving it IV because of QT issues, certainly IM is an option. And in my personal experience, I have about a 50% success rate getting people who are usually admitted to instead feel well enough to go home, which I think is not too bad. Ketamine certainly is an option, but probably for patients who have pain over nausea is more their predominant symptom, since some nausea is a pretty common symptom of subdissociative ketamine. IV Lidocaine may be useful, especially affecting the spinothalamic tract and trying to interrupt this pain signaling. And then IV benzodiazepines for nausea can sometimes help as well. And then lastly, now that you know a little bit about the long-term treatments for centrally mediated abdominal pain, it's important to help try to get the patient in to follow up for that. So in my own practice, we use EPIC, and I have a dot phrase that I use for these patients that explains why I think they need to see the gastroenterologist and why I think they need to see mental health and what they can expect to get from those visits so that they will follow up with them. Because, you know, willingness to follow up is a really important part of that. Along those lines, you know, letting patients know that there is treatment and hope and there are ways to manage these symptoms beyond having to come to the emergency room and then just sit at home the rest of the time is a really powerful medication all by itself. I had one woman who I saw with her son who was there probably for the 4th or 5th time. They were new to our healthcare system, but through EPIC, of course, I could see she'd had a pretty extensive workup, seen many doctors for her abdominal pain, did not seem to have any particular structural cause of that, and in fact had a pretty classic presentation of centrally mediated abdominal pain. She met all of our diagnostic criteria. When I talked to this woman, I said, well, what have your doctors told you about what's wrong with you? And she said, they tell me there's nothing wrong with me, that I should be fine, but every day I have this, and sometimes it's so bad I have to go to the emergency room. And we started to talk about centrally mediated abdominal pain, and I said, you know, I think there really is something wrong here, but your doctors are partially right in that it's not that your insides aren't put together correctly, but the way your brain is processing what should be normal signals from your gut make you feel bad, even though the inside of your gut works okay. And this woman just started crying, pouring tears, because no one had ever talked to her about this before and let her know that it was okay that she felt bad, that that was a real thing, and that there might be hopeful treatments for that in the future. So I hope that leaving here, you know a little bit more about centrally mediated abdominal pain and may have some tools to use to help both improve your effectiveness at the bedside with these patients and also give these patients a little hope about what other treatments might be available to them. And that's it for me, so if you guys have any questions, I'd be happy to take them. Yes? So I have the advantage that I've already seen it on the ultrasound, so I know where their actual abdominal wall is. And the nerves that we're interested in are mostly subcutaneous. So I usually will just drop 20 cc's of Marcaine in. They should be able to fairly discreetly tell you, or with Carnett sign, you should have identified a fairly localized spot that's the worst spot. So I'll put about 20 cc's of Marcaine into the sub-Q tissues in that area. Yes?
Are these patients with this intermediate abdominal pain, do they also, in your department, have kind of ongoing care plans established so that if they come in, you're not working,
yes,
that partners are not just loading them with Dilaudid and sending them away?
So oftentimes they do, but not always, no. And so I have delivered this talk to my faculty as well, and we're moving practice as a group that way. But that's a challenge for all of our patients. I mean, a great example would be our sickle cell patients all do have care plans, and even their compliance with their care plans is not 100%. And that is an important reason why having this conversation with the patients is important. Once they have a better understanding of what's going on, when they meet the next provider, they can say, I saw Dr. Glass the other day, and he explained how my nerves don't work good, and that makes me sick. And when I got the haloperidol, I felt a lot better, and could I have that instead? And we have had patients come in and ask for that after having a good experience with it. Yes?
I got like a multi-part question about the drugs.
Sure.
So, first part one is dosing the haldol.
Yeah.
If it's effective, what do you send them home on? And
yeah.
The third is, do you have concern, you mentioned benzos, about the addiction potential of that?
I don't often use benzos because I'm concerned about the addiction potential, so that's, for me personally, one of my last lines. For the haloperidol, I typically give 5 milligrams IV. In my experience, for adult-sized people, they don't get sleepy. They might snooze a little bit, but typically within 2 hours of arrival or 2 hours of being bedded, they're ready for a reassessment and most of the time want to go home. If I give multiple doses, I usually check an EKG then. And before I give the first dose, if I have records, I will go back to see if there are any other QT prolonging stuff or have an old EKG. So I do a little bit of homework because I'm not super worried about the QT, but I'm not ignorant of it either. When I send them home, I don't usually send them home on Haldol because I don't want to be responsible for tardive dyskinesia. And quite frankly, there's not really any evidence about long-term home use modification of these symptoms with the antipsychotics. And so really at home, they need to be on the TCAs or the SSRIs. And again, I'd rather their gastroenterologist did that. Certainly, I have colleagues who are not comfortable with giving haloperidol IV, and IM is an alternative. It just may take longer to work, and of course, the effective dose might need to be a little bit higher to get the same kind of result. Any other questions? I appreciate your patience. Thanks, everybody.